the arterial approaches for brain dural arteriovenous fistulas. In general, as Carol pointed out, at the Toronto Western, for benign dural arteriovenous fistulas, I classically tell the patient that he is in the driver or she is in the driver's seat, i.e., if the patient wants treatment, we can certainly do so, but we don't have to treat. We would only treat if the bruit is intolerable. We had patients who were suicidal, we had patients who lost their jobs because of the bruit, because of not being able to sleep, who divorced even. So there are, not every single tinnitus is benign, and those who have intolerable one, we will treat. I showed you the case of the patient with the increased intracranial pressure. That also was a benign dural arteriovenous fistula by the basics of the Toronto classification or the Cognard Board classification. Still, the patient had significant headaches, and we thought that treatment was indicated. And some patients with dural arteriovenous fistulas even can get, although they are classified as benign, significant problems with their vision, and then treatment is also indicated. If you opt for conservative management, which is a viable option if the patients tolerate their symptoms, re-image if there's a change in symptoms and tell them that they should come immediately to you. If you have a so-called malignant one, we always try to complete the treatment, and there are different ways, endovascular surgical ways. We personally, the Western, I would say, treat more than 90% now via endovascular means, and it's very rare that we go for surgery, mainly at the level of the foramen magnum and for the ethmoidal dural arteriovenous fistulas. And Alan Taylor will speak more about the surgical approaches. From an endovascular, Insuf will speak about transvenous, and I will focus now on trans-arterial. Some general strategies. It is extremely important that you know what your target is in a dural arteriovenous fistula, in any type of shunt for this matter. Your target has to be the most distal portion of the artery, together with the nidus, and the proximal portion of the vein. If you are only ligating an artery, then the dural arteriovenous fistula will come back. And it always will come back, that's a given. And you have made the life for the next interventionist now significantly more difficult, because you have maybe taken out the best possible access. So a ligation embolization with coils or liquid embolic that does not reach into the venous structure will lead to recanalization. Particles have no rule in dural arteriovenous fistula. They also have a high propensity to recanalize or even anger the dural arteriovenous fistula, because what we have found from animal experiments, the two necessary conditions for dural arteriovenous fistula to develop are A, venous hypertension, and B, VEGF increase. If you only have venous hypertension, you will not develop a dural arteriovenous fistula. If you only have VEGF, you will not develop a dural arteriovenous fistula. You need to have both, at least in the animal experiments. And we have written recently an article on this, where we put the current knowledge as a review together. Go as distal as possible with your catheter and use liquid embolic material. And we will talk about now the pros and cons of glue versus onyx, fill, and squid. In between onyx, fill, and squid, I personally have no preference. I think you can use all three of them. I personally, most of the time, I have no disclosures, use onyx. The general strategy is that you have to evaluate the fistula, which means that you need to identify all supplying feeders, then choose the most direct or safe one, and identify the potential dangerous vessels. So here we can identify that the middle meningeal artery and the occipital artery are the main feeders of this case. We can identify where the vein starts, where the shunting zone is, and where the bleed has happened, and we can identify our security margin, or the so-called dangerous vessels that you've heard yesterday from me. So there are no dangerous vessels, but only dangerous doctors that simply don't know the anatomy. Then determine the target. The target has to be the distal artery together with your proximal vein. So this is the segment to be excluded in the perfect world. Then identify your security margin, which in this case here is really all the way back to this region here. So you're very safe. This is your distal catheter. If you're using glue, get yourself into a wedge position, or else where the glue will actually stop and harden on contact with the unglucosed blood. You can see here that the artery got filled. We have venous penetration into the pouch. You don't want to overshoot. You don't want to get too much into the vein here to prevent overshooting thrombosis. And then you will have to check all the other potentially supplying arteries, and then you are done for the next 3 months. And in 3 months you bring the patient back for control angiography to ensure that the fistula has not recanalized, in case, especially if you're not sure whether you have enough penetration into the veins. Since glue is thrombogenic, you will have, if you reach the vein with glue, less likelihood of recanalization, but especially if you're using onyx and you have not overshot the target, then sometimes these fistulas can come back if you have not treated all of the different channels. When do you consider a venous approach? If a trans-arterial approach is unlikely to lead to success or is deemed too dangerous, so for example, if you are close to the ECIC branches, classical location where I would never, ever treat from the trans-arterial approach is the cavernous sinus region, because of the significant supply or interconnections with the ICA. You can only consider a venous approach if the brain does not use the venous segment to be occluded, and therefore these are the ones like classically cavernous sinus and marginal sinus, where transvenous approach is the best thing to do. Now let's go back into the trans-arterial approach and our differences between onyx with fill versus glue injection. So let's say we have an artery here, another feeding vessel here, here's the shunting zone, and this huge thing here is your draining vein, okay? So then what you are doing with onyx with or fill is that you start injecting. At one point in time, you will get reflux. The reflux will then make a plug, and you can reflux into your distal, into your other arteries. And then you have to ensure that you completely fill the venous pouch. So I classically tend to over-inject. I continue to inject and continue to inject and continue to inject until I'm sure that we have occluded the entire fistula. Glue is completely different. In glue, you go in there, try to wedge yourself, and then you inject the glue that immediately, when it reaches unglucosed blood, hardens upon contact and will be thrombogenic. In this case here, even a droplet of glue would have been able to cure this fistula, because we've plugged the entrance here. Because we were lucky that we were wedged in this vessel here. However, if we are wedged in this vessel here, what will happen? We inject the glue, and in the moment where the glue comes into contact here with a second branch that is having unglucosed blood, it will harden already here and not there. And therefore, you will not be successful in embolizing this dural arteriovenous fistula with glue if your microcatheter happens to be here and not here wedged. Or if your microcatheter, by the way, is not wedged at all, then it is very difficult to penetrate with the glue, at least in my hands, all the way into the venous structure. And I will give you an example for this. So here are the pros and cons of glue versus onyx, fill, or squid. And we will go through them, and we are now talking about a couple of cases. So, a major problem with glue is that it hardens upon contact with blood. And then this can happen. Let's have a look here. We have this thing here, so it hardens there. This one would not harden. We have this patient who presented with cognitive decline, significant cortical venous reflux, massively dilated pouches, and multiple feeding artery. Remember to always map the entire dural arteriovenous fistula. And so I decided to go after the biggest one first. So I went with a microcatheter through the middle meningeal artery, thought I was in a nice distal position here, started to inject my glue, and here is the glue cast. And you can see that the glue hardened on contact with blood coming from all of the other vessels, but did not reach the venous pouch. And the dural arteriovenous fistula was still quite alive, as you can see here. So we went into the next vessel, and again the glue cast did not reach the vein. We went into the next vessel and the next vessel, and finally we understood that we cannot treat this dural arteriovenous fistula with glue alone. And so we went into the last potential vessel, the posterior meningeal, and this is where we then injected onyx here, and we started to inject. And since onyx does not harden upon contact with blood, you can continue and continue and continue to inject until we have stasis here upstairs in the pouch, and you know that the dural arteriovenous fistula is cured. And here's the final onyx cast. And this would have been very difficult, if not impossible, to achieve with glue, at least in my hands. So, what are the problems of onyx, squid, and fill? And we will go through this picture that is now a little bit more complex as just before. So let's say we are here in the middle meningeal artery, and we do know that there are anastomosis between our external carotid artery and our internal carotid artery. And let's say that this is one of these anastomotic channels, for example the MHT and the ILT. Let's imagine that we have our fistulous zone here. Let's imagine that this vessel here gives supply to like the cranial nerve 7. So let's say this here is the petrous squamosal branch right here. And now look at the venous pouch here that has bled, but here we have normal brain that is draining into this vein that then goes out here. Okay? So onyx, fill, and squid can have multiple problems that we'll need to understand. Number one, when we are starting to inject and make the plug, we ideally want to get into the vein and completely fill it. That's in the perfect world. However, if you now start to get reflux while building the plug, the reflux can go back to where we have an ECIC anastomosis, and it may not just stay there, it may go through this small vessel and then cause a stroke. Now this vessel here, these are tiny vessels, and you may not be able to see them, but they are always there, period. So if you are, let's say, doing the major mistake for which you will be sued to treat, let's say, a dural arteriovenous fistula of the cavernous sinus through a trans-arterial approach, all of a sudden you will see a tiny droplet of your onyx being sucked into the ILT and then bang being into the ICA. And this vessel is so small that even a droplet of onyx will travel very far and will cause a stroke. So just simply don't do it. So this is one of the risks that you have. So you really need to know your anatomy. The second problem that can happen is if you now get reflux into one of those vessels that lead to your cranial nerve supply, then you can have cranial nerve palsy. And this was recently described in the Journal of Neurointerventional Surgery, where on the cover a beautiful, quote-unquote, onyx cast of the facial arcade was. And these authors presented this case as if they were the first one to ever identify the facial arcade. They just didn't read the literature or the anatomy. Now, and here it doesn't even end with the problems of onyx squid and fill that you need to understand. If you over-inject and you get your onyx fill or squid into normal draining veins, then you may get venous congestion and venous hemorrhagic infarcts. So in this case here, you need to know not only your arterial security margin, but you also need to know your venous security margin, which is something that is not so much a problem with glue because it just hardens earlier. So the main thing with onyx is you need to know your anatomy if you want to embark on onyx treatment. It appears to be easier to control as compared to glue, but you really need to know the anatomy. And this is, if there's maybe one article that I can recommend, this one here, together with Sirintara, we discussed about the dangerous EC-IC anastomosis and supply to the cranial nerve, the vessels you should need to know. And remember the EC-IC anastomosis, they are always there. The cranial nerve supply, you never see it. You need to know where it is. And you'll have to look for the normal brain venous drainage. So let's go through a couple of examples. First, potential EC-IC anastomosis. Yesterday's entire day was focused on this, and I really recommend you to reread it and listen to Insub's lecture again and again, because it is so important to know where you can estimate where you have the supply, or where you have your EC-IC anastomosis. You need to know your cranial nerve supply. Again, yesterday's lecture from Insub is so extremely important for this identification. But also on the venous side, you need to know your safety margin. What is the proximity of the venous segment to be excluded in relation to the normal venous drainage? So for example, if you have a transverse sinus dural arteriovenous fistula, you will always have to look for the proximity of the vein of Labbe in relation to where your onyx will likely go, because you don't want to get the onyx into the vein of Labbe, especially not if it's a dominant vein of Labbe. Likewise, you have to look for cerebellar hemispheric veins. And then, as Carol pointed out in his talk about venous anatomy, every single venous anatomy of every patient can be different. You may have a dominant vein of Labbe that is not interconnected with the Rolandic vein or with the Trolar vein. And remember what Carol showed you yesterday when we talk about venous anatomy. When we talk about venous anatomy, we need to understand that there are like groups of veins that can be interconnected with each other. So we have the mediodorsal group, that's the one that classically drains like the Rolandic artery, the Rolandic vein or the vein of Trolar into the superior sagittal sinus. We have the ventrolateral group, that's the group that is where the hallmark vein is the vein of Labbe that drains into the transverse sinus. And the third group is the anterior group that will drain into the middle superficial cerebral vein that can drain into the cavernous sinus. And these three veins, or groups of veins, can be separated or they can be interconnected. So here you can see, for example, that in this individual patient, the ventrolateral group, the Labbe group, is interconnected with the mediodorsal group, which means that if you occlude this vein here, when you're doing a trans-arterial treatment, and your onyx goes into this segment and the onyx goes into the vein, it would not be so much of a problem as compared to occluding this origin of the vein here. Because this vein here is not interconnected with any other vein. Or this vein here, major Labbe vein, it's not interconnected. You have here an isolated system where maybe the mediodorsal group is interconnected with the anterior group right here through this channel. So each venous anatomy is completely different. Therefore, when you do your diagnostic angiography in a dural arteriovenous fistula, keep it always deep into the venous phase. For your safety margins on the venous side, if you are treating from an arterial route, the easiest one is, of course, if you have an isolated sinus. If you have an isolated sinus, the sinus is not any longer used. Here we have an example with this cortical venous reflux. That's your classical isolated sinus. You have thrombosis here, you have thrombosis here, so the fistula can only go back towards the brain. This is a good indication for treatment from a trans-arterial point of view. Here, the example that is just showcasing you the anastomotic possibilities of the middle meningeal artery with the occipital artery, and it shows you that the transosseous branches that classically arise from the occipital artery are often very tortuous and are more difficult to penetrate into, and therefore, whenever I have the choice whether I go through osteodural branches or meningeal branches, I would always choose the meningeal branch, although it may be smaller, but it's always easier to penetrate from a meningeal branch. As you can see here, there's the microcatheter injection. See nicely the reflux here, and we have an isolated sinus here, easy to treat. We were in a bench position and we were able to completely obliterate this sinus here, and then of course we have to control the occipital artery. What about parasinus? So we are now not talking into isolated sinus, but a parasinus. Here I showed you already this example. This is the patient's left-sided ECA injection and the right-sided ECA injection. And this side, dural arteriovenous fistula, is important to realize it's not going into the superior sagittal sinus. It's going actually lateral into a parasinus right next to the superior sagittal sinus. How do we know? By doing a little bit of more fancy imaging. And I do like this vaso-CT, as it does allow you to identify where exactly is the shunting zone. You can see here the arteries are very bright, the veins are of intermediate signal if they are the primary draining veins, and they are really dark if they are not being used. And you can see here that the shunting zone is right here, okay, and then goes from here into the large cortical vein, and then only later reaches the superior sagittal sinus, which means that I don't need to do a balloon protection in this patient here for the superior sagittal sinus because it's in a parasinus. And we can see this also nicely here on the axial ones, where you see that the shunting zone is actually lateral, right there into a cortical vein, right next to the superior sagittal sinus. So then you go as far distal as possible, and you start to inject your onyx. And once you're reaching into the vein, I classically tell my fellows to stop and go, i.e. briefly stop, then inject again, and then do an onion skin layer in the vein. I do not want to penetrate too deep into the vein. If you just stop and wait too long, you will have lost your possibility of moving forward. If you continue to inject, you will plaster the entire cortical vein, which you don't want to. So therefore, stop, go would be my typical way of like that injecting. Until I then start to reflux into other arteries, which is the goal of my treatment. What do you do if the sinus is still in use and you want to treat it trans-arterially? Well, here we have an example. This patient had a benign dural arteriovenous fistula, but he had already attempted once suicide because he could no longer tolerate it. And here we felt that he needed treatment. But the brain needed the segment that we thought about excluding, because there's clearly here drainage going into the sinus, and we see that the cerebellar hemispheric veins also still use the sinus here. So therefore, this is not a good case for like treating the patient transvenously by coil occlusion of the entire segment. So we decided to have a protective balloon here, go as distal as possible from the arterial side, blow up the balloon to keep the lumen of the sinus patent, and then plaster the entire thing with onyx, knowing our security margin here towards the facial arcade, going towards here. What is of importance is sometimes that the fistulous zone is very close to, let's say, the origin of the vein of Labé. Then I may have a second balloon catheter, classically a septor C, to protect the origin of the vein. And here's the final control. We can see nicely that the fistula is cured and the sinus is patent. A couple of nuances in surgery. Here we had a patient where we had a very high flow shunt. Normally at the region of the sphenoid ridge and cavernous sinus, I do not treat trans-arterially, as I told you, but I felt that transvenous approach here would be too tortuous, and I felt that this is a slightly atypical dural arteriovenous fistula, as we see massive dilatation of the feeding artery that has a direct massive shunt here. So in this case here, we were in fact able to go from trans-arterial all the way into the venous pouch, so trans-arterial to transvenous treatment, and then coiled backwards and finished the job here, still being in the vein with a little bit of glue injection at the end. Now what is important in this patient here is, and why I'm showing it, is one important operative nuance, and this is that if you have these massively dilated pouches that I showed you here, and you completely take a high flow shunt, this is not a low flow shunt, then you're facing the potential risk that this patient develops overshooting thrombosis. And with this I mean that now the dilated venous pouches, they do no longer get the normal arterial input, and now there may be in these pouches thrombus formation. And so I keep these patients under heparin for up to, in this case here, 6 hours after the treatment. And then we do a baseline CT to see at the time where we stop the heparin how much occlusion do we already have. And then I wait for 6 hours, sometimes even longer, and do another CT. And if I then see between the two different unenhanced CTs that there's progressive and overshooting thrombus in veins that are used by the brain, then I need to continue the heparin. So in this patient here, after stopping the heparin, the patient complained about headaches and onset of vomiting, and you see that in those pouches we see now for like significant thrombus formation, and we see thrombus formation even distant to where the shunt was going to, i.e. where the normal brain is now at risk for sinus thrombosis. And so what we did in this patient here, and what I can recommend you is that you have to continue heparin for a longer period of time. The longest that I had a patient on heparin was I think 3 weeks, because the patient continuously thrombosed his veins whenever we stopped the heparin, because they were so dilated, and we just needed to give the veins the time to shrink back to their normal size. I still have, I think, a couple of minutes, so let's talk a little bit about the newest kit on the block. Again, I do not have any disclosures to make, but I have to admit that I really like the Septor Mini Balloon, as it allows us to go quite far distant and make a pressure cooker without having to put in multiple catheters. So what do we mean with pressure cooker and mini balloons? So here is an example of a patient with cortical venous reflux. The patient developed ataxia, significant high flow, and not so really good like middle meningeal supply here, but a monster occipital artery right here. But remember what I said, the occipital artery is really difficult to penetrate unless you have a pressure cooker. And a pressure cooker means that either with coils or with glue, you seal the blood vessel, and therefore your onyx can only penetrate forward, because otherwise the onyx would go a path of least resistance, which would be going actually back into the occipital artery. And you don't want your onyx there, you want your onyx right there. So plugging the occipital artery allows this pressure cooker to form, which means that the onyx can only move forward, which led to complete obliteration in this example here, with the coils being here, and you see nicely how we penetrated here through the bone to reach into the venous segment. Also, look again, we don't want to have more venous thrombosis than this here, so be generous with your follow-up CTs. Okay, I will talk, I think, later. I'll give you some example of mini balloons, but first, a couple of other technical nuances. You can go through dural branches from pile arteries. I think because of the lack of time, I will actually skip through this one and maybe keep this for the workshop. Okay, and I think yeah, we will keep this maybe indeed for the workshops. I'm sorry. Okay, but I did want to speak a little bit to conclude here for the trans-arterial approach for dural arteriovenous fistula. Definitely it's liquid embolics are the first choice. I would recommend you to do one thing, not to move too much from one embolic agent to the other to the next. In my opinion, they behave very similar to each other, but with each one you may have a new learning curve, so I would stick to one. Try to use meningeal vessels, know the anatomy, anticipate the potential collaterals and the cranial nerve supply. I think it's important to realize that it's not only an arterial security margin, but there is also a venous security margin. There are good indications for venous approaches, especially when we're talking about the cavernous sinus region or the foramen magnum region. And do remember what Pierre used to say, that anatomy is the cheapest way to be safe. Thank you very much.